Slow pulse rate or complete heart block. Instruction by the examiner. Examine the pulse and examine the CVS. Examine the pulse and precordium. Presentation of a case. Pulse is 40 beats per minute. High volume, normal rhythm, no radiofemoral delay. Condition of the vessel wall is normal. Blood pressure is 150 over 70 millimeter mercury, that is wide pulse pressure. Neck pain. Occasionally cannon waves are present. In the precordium, variable intensity of first heart sound. There is a systolic flow murmur due to increased stroke volume. So my diagnosis is bradycardia. What is the most likely cause in this case? The cause may be complete heart block or drugs such as beta blocker, digoxin or verapamil. What are the causes of bradycardia? The causes are sinus bradycardia due to any cause, second degree heart block, complete heart block, nodal rhythm. Causes of sinus bradycardia: physiological due to increased vagal tone, athlete during sleep; pathological, acute inferior myocardial infarction, myxedema due to reduction of sympathetic activity; hypothermia, raised intracranial tension due to inhibitory effect on sympathetic outflow; obstructive jaundice due to deposition of bilirubin in conducting system; drugs, digoxin, beta blockers, amiodarone and verapamil. Why variable intensity of first heart sound and systolic murmur in complete heart block? Variable intensity of first heart sound is due to loss of AV synchrony. Systolic flow murmur is due to increased stroke volume. Now, what is the mechanism of cannon wave? Due to loss of AV synchrony, when atria contracts against closed tricuspid valve, backward pressure produces cannon wave. Now, what is the ECG change in complete heart block? Complete dissociation between P and QRS. Heart rate is less than 40 beats per minute. If pulse rate is high, what are the likely causes of complete heart block? As follows: pulse rate is high in congenital complete heart block and does not require treatment if the block occurs more proximally in AV node. Narrow complex escape rhythm. What are the presentations of complete heart block? The presentations are dizziness or giddiness, weakness, blackout or sudden loss of consciousness, syncope, Stokes-Adams attack. Now, what are the causes of complete heart block? The causes are acute complete heart block, acute myocardial infarction, commonly inferior; chronic complete heart block, idiopathic fibrosis due to progressive fibrosis of distal His-Purkinje system, Leib's disease in elderly; progressive fibrosis of proximal His-Purkinje system, Lenegris disease in younger. Other causes of complete heart block, usually chronic: cardiomyopathy, ischemic or idiopathic dilated myocarditis, calcific aortic stenosis; drugs such as digoxin, beta blockers, amiodarone, verapamil, diltiazem; cardiac surgery, aortic valve replacement, VSD repair and CABG; radiofrequency ablation of AV node and pacemaker implantation; infiltrative disease such as sarcoidosis, amyloidosis and hemochromatosis; infection such as infective endocarditis, Chagas disease and Lyme disease; collagen disease such as SLE, rheumatoid arthritis; congenital complete heart block, common in child of SLE mother, transposition of great vessels; neuromuscular cause such as Duchenne muscular dystrophy. Now, what is the cause of congenital heart block? Congenital heart block usually occurs if the mother is suffering from SLE due to the presence of anti-Ro-SSA antibody, which crosses the placenta and causes congenital heart block. What are the signs of complete heart block? Pulse is bradycardia, 20 to 40 beats per minute. High volume pulse does not increase by exercise or injection atropine. Blood pressure high systolic, normal diastolic and wide pulse pressure. Neck pain, cannon waves, large A wave may be present. Heart sounds, variable intensity of first heart sound. Murmur, systolic flow murmur due to increased stroke volume. When AB conduction fails completely, atria and ventricle beat independently. That is called AV dissociation. Ventricular activity is maintained by an escape rhythm from two sides, arising in AV node or bundle of His narrow QRS complexes with more heart rate. Distal Purkinje tissue broad QRS complex with slow heart rate. Stokes-Adams attack usually occurs. Now, how to treat complete heart block? If symptomatic, permanent pacemaker should be given. Implantable cardioverter defibrillator (ICD) indicated in those with severe left ventricular dysfunction, that is more than 0.3-second duration. What is Stokes-Adams attack? What are the clinical features and treatment? It is the brief attack of syncope or blackout in a patient with complete heart block due to ventricular asystole. Stokes-Adams attack may also occur in Mobis type 2 heart block, ventricular tachycardia or fibrillation, sinoatrial disease. Clinical features are syncope or blackout with or without preceding dizziness. During attack, patient is unconscious, looks pale, and may have convulsion. If asystole persists, there may be cyanosis, pulse is absent, incontinence of urine, pupil is fixed, and dilated, plantar is extensor. Usually conscious recovers rapidly followed by flushing. Now, treatment. Permanent pacemaker even after a single syncopal attack. During attack, CPR should be done.